The red eye. It's one of those things you see everywhere in medicine, right?
Oh, absolutely. Doesn't matter if you're in primary care, the ED, an eye clinic.
Yeah.
It walks in the door constantly.
Yeah, and it feels like it should be simple, but well, there's actually a lot to unpack there if you want to get it right.
Mm-hmm. It really is foundational knowledge. Whether you're a med student seeing your first one or, a seasoned consultant or optometrist refining things,
Mm.
having a solid approach is key.
Totally agree. So for this deep dive, we've gathered some really good stuff. We've got that strong medicine video transcript, which is excellent, plus some practical takes from MDocs and Medscape articles.
Yeah, the idea is to kind of pull the best bits from all of them, synthesize it into something really practical for listeners.
Right, like move past just listing symptoms and actually build a thinking framework.
Exactly. So whether you're building that first mental toolkit or just sharpening the one you have, hopefully this gives you some real actionable insights.
That's the plan. Cut through the noise and focus on what helps you tell the difference between, say, simple pink eye and something that could really threaten vision.
hmm So structure-wise, we figured we'd start with the anatomy. Got to know the parts, right?
Right.
Then we'll use that to build a diagnostic framework, look at key history and exam bits, and then dive into specific conditions, really hitting those urgent ones hard.
Perfect. Okay, let's jump in. Anatomy first. Based on that strong medicine overview, what are the big landmarks we see right away?
So externally, you've got three main things staring back at you. The iris, that's the colored part.
Okay.
The pupil, which is just the hole in the middle letting light in.
Sure.
And the sclera, the white part.
The tough white outer coat.
Exactly.
Yeah.
And remember, the sclera goes all the way around, forms a whole globe. Then covering the iris and pupil, you have the cornea.
The clear dome at the front.
Right, the clear dome. And it's continuous with the sclera. They meet at that little junction called the limbus.
Okay, got it. And moving just slightly deeper, the anterior chamber.
Yeah, so the anterior chamber is that space between the back of the cornea and the front of the iris.
Mhm.
It's filled with aqueous humor.
And behind the iris.
That's the posterior chamber,
Oh.
also filled with aqueous. And tucked in there, next to the iris, is the ciliary body. Super important structure.
Right, because it does two main things.
Two crucial things.
What?
One, it has muscles that change the lens shape so we can focus. That's accommodation.
Mm-hmm.
And two, it actually produces that aqueous humor we were just talking about, which keeps the eye nourished and maintains the pressure.
Okay. Now, strong medicine groups a few of these together, iris, ciliary body, and something else into the uvea. Why is that grouping significant?
Right, the uvea. It's the middle layer, the vascular layer.
Mm.
Includes the iris, the ciliary body, and the choroid, which is that blood vessel layer under the sclera.
Okay.
Clinically, it's important because inflammation often hits these related structures. So you hear uveitis is inflammation of the iris, but often the ciliary body is involved too, because they're right there together.
So that's why uveitis and anterior uveitis are often used kind of interchangeably.
Exactly. Anterior uveitis technically means iris and the front part of the ciliary body are inflamed.
Makes sense. Okay, so we've done the front bits. What about the white of the eye? You mentioned the sclera, but it's layered, isn't it?
Yeah, this is a really key point.
Yeah.
The very, very outermost layer isn't the sclera itself. It's actually the conjunctiva,
The thin, clear membrane.
the thin, clear membrane, yeah.
Yep.
Covers the white part you see and lines the inside of your eyelids.
Okay, then under that.
Under the conjunctiva, you hit the episclera, the thin layer, got some blood vessels, connective tissue.
Mm-hmm.
Then you get to the sclera proper, the scleral stroma. That's the dense, white, tough part.
Giving it the color and strength.
Right. And then the very deepest layer of the sclera, right up against the choroid, is the lamina fusca. It's a bit more pigmented.
And knowing these layers matters clinically, right?
Yeah.
Especially for episcleritis versus scleritis.
Hugely important. Episcleritis, inflammation of that superficial episclera, is usually, less intense. Maybe some sectoral redness, a bit of discomfort, vessels look kind of radial, and they move if you gently push with a cotton swab.
Okay.
Scleritis, though, that's the deep sclera proper. That's usually much more painful, like a deep, boring ache. The redness can look more purplish or bluish, maybe nodular, and those deep vessels, they don't move easily. Plus, scleritis can actually threaten vision. Big difference.
Wow, okay. That anatomy breakdown really helps set the stage. So, patient comes in, red eye. How do we start applying this? You mentioned the strong medicine framework and that MDocs mnemonic.
Yeah.
HCG, FUNKS.
Yeah, exactly. Knowing the anatomy lets you think, okay, where could the problem be? The HCG, FUNKS, is great for remembering the scary stuff you can't miss.
Let's see if I remember. Hyphema, corneal ulcer abrasion.
Yep. Acute angle closure glaucoma.
Foreign body or globe rupture.
Good. Uveitis, the severe kind.
Neovascularization. Maybe less acute red eye itself, but serious underlying cause.
Right. Keratitis.
And scleritis or endophthalmitis. Okay, that's
Yeah.
a good checklist for the oh no moments.
Definitely. But for our general approach, let's stick with that outside-in anatomical structure. Starting with the eyelids, what red things happen there?
Okay, eyelids. Styes come to mind first.
Yeah, or hordeolum, that's usually an acute bacterial infection in an oil gland.
Mm-hmm.
Painful red bump, right?
Right. Different from a chalazion.
Yeah, chalazion is also a blocked oil gland, but is usually not infected, so tends to be painless, maybe develops more slowly, feels more like a cyst.
Got it. What else on the lids?
Blepharitis, that's more of a chronic inflammation right along the eyelid margin. Think redness, maybe some scaling near the lashes, and then moving slightly deeper, periorbital cellulitis.
Or perceptal cellulitis.
Mhm.
And the key there is where the infection is, isn't it?
Exactly. Periorbital or preseptal means the infection's in the eyelid and the tissues in front of the orbital septum.
So not inside the orbit itself?
Correct. No involvement of the orbital fat or the eye muscles. If you do see signs of deeper involvement, like pain when the patient moves their eye, the eye bulging forward, proptosis, or vision changes, then you're worried about orbital cellulitis.
And that's a whole different level of emergency.
Huge emergency. Needs very urgent treatment.
Okay, eyelids checked. Moving on to the main event, the conjunctiva and sclera. You said the pattern of redness is key here.
Yeah, the hyperenemia pattern tells you a lot. Starting superficially, the most common thing causing diffuse redness is conjunctivitis inflammation of that conjunctiva membrane.
Pink eye.
Right. Can be infectious bacterial, viral, or allergic, or even from chemical irritation. Pain is usually mild or absent. Vision's okay. The redness is typically spread out, maybe spares that little ring right around the cornea, the paralimbic area.
But not all conjunctivitis is created equal, right? What about Neisseria?
Ah, yes. Strong medicine rightly flags Neisseria conjunctivitis as a major emergency. It comes on fast, hyperacute, like within a day. And you see tons of thick, pus-like discharge, often linked with urethritis. Huge risk of the cornea getting involved in causing vision loss. You got to think about it. Ask the right history questions, like MDocs points out, for both Neisseria and chlamydia too.
And differentiating regular bacterial from viral.
Generally, bacterial has more of that thick, purulent discharge. Maybe the eye feels glued shut in the morning. Viral tends to be more watery. Maybe you feel swollen glands in front of the ear, often comes with a cold.
The allergic.
Itching. Itching is the hallmark of allergic conjunctivitis.
Mm.
Plus watery discharge, maybe puffy eyelids, often both eyes.
Okay. So that's conjunctivitis. What about redness from the deeper layers, episcleritis and scleritis?
Right. Episcleritis, remember, is the superficial layer under the conjunctiva.
Mm-hmm.
So the pain is milder,
Mhm.
often just discomfort. Vision's fine. The redness might be just in one section, kind of radial vessels, and they move.
Mm-hmm.
Scleritis, the deep layer, is the one with the real pain. That deep, boring ache, maybe worse at night, hurts to move the eye, like strong medicine and core EM both mentioned.
And the look is different, too.
Yeah, the redness might have that bluish or purplish tint, and those deep vessels, they just don't move when you gently push on them. Much more concerning.
What about that sudden, scary-looking patch of pure red, subconjunctival hemorrhage?
Exactly. Looks awful, but usually totally benign. Just a broken blood vessel under the conjunctiva, no pain, no vision change, usually happens on its own or with coughing, straining.
But there's a caveat.
Yeah, strong medicine mentioned if it's all the way around the eye, 360 degrees, you have to worry about significant trauma, maybe even a globe rupture. That's different.
Good point. And can dry eyes cause acute redness?
They can, especially if it's a flare-up or pretty severe. Lack of tears causes irritation, inflammation. Can look a bit like mild conjunctivitis. Patients often complain of burning or a gritty feeling. If it's bad, you might even see tiny spots on the cornea with fluorescent dye.
Okay, good rundown of conjunctiva and sclera. Moving inward again to the cornea itself. What causes redness there?
Corneal abrasions are super common, scratches on the surface, often from trauma or a foreign body. And the cornea is packed with nerves, so even a tiny scratch can cause major pain. Feels like something's still in there.
And fluorescein helps see those.
Oh yeah, fluorescein dye under blue light makes abrasions light up like a Christmas tree. And speaking of foreign bodies, they can get stuck anywhere. Cornea, conjunctiva, under the eyelid. Always got to look, especially if someone wasn't wearing eye protection, like the strong medicine video warns.
Right. Then there's keratitis, inflammation of the cornea.
Yep. Inflammation or infection of the cornea itself. This is where you might see that ciliary flush we talked about, that ring of deep red vessels right around the edge of the cornea. Tells you the inflammation is deeper than just conjunctivitis.
And you might see things on the cornea.
You might. White spots, maybe those branching patterns if it's herpes simplex keratitis. And always, always ask about contact lenses. Huge risk factor for nasty bacterial keratitis, especially Pseudomonas.
Okay. And what about UV keratitis, like welder's flash?
Right, photokeratitis. The classic thing is the delayed pain. Doesn't hurt right away, but 6 to 12 hours after the UV exposure welding, bright snowbam, severe pain. And the fluorescein pattern is usually lots of tiny dots all over the cornea, but it spares the inside of the eyelids.
Interesting. Okay. Deeper still. Anterior chamber issues causing red eye.
Top of the list, got to be acute angle closure glaucoma. That's when the fluid drainage system gets blocked suddenly, pressure spikes way up.
And the symptoms are dramatic.
Usually, yeah. Strong medicine described it well. Intense pain, maybe headache, blurred vision, seeing halos around lights, sometimes nausea, vomiting. Exam-wise, you look for a pupil that's kind of mid-dilated and doesn't react well, a hazy-looking cornea, and that ciliary flush again.
The big don't.
Do not dilate the pupil if you suspect angle closure. Makes it worse. Big no-no.
Got it. What else in the anterior chamber? Uveitis.
Anterior uveitis or uveitis, inflammation of the iris, maybe the ciliary body too. Pain is usually moderate to severe, aching, and photophobia is key. Especially consensual photophobia light in the good eye makes the bad eye hurt. Both strong medicine and MDocs hit that point.
What does the eye look like?
Ciliary flush again. The pupil is often small, maybe irregular shaped, sometimes dilated, but usually constricted. And you often find links to systemic inflammatory diseases, so you got to think about that bigger picture.
Okay. And blood or pus in there?
Right. Hyphema is blood in the anterior chamber, usually from trauma. MDocs mentioned grading it based on how much blood there is. Risks are high pressure, staining the cornea. Hypopion is pus, well, white blood cells layered in the bottom. You see that with severe infections like keratitis or endophthalmitis.
Yeah.
But MDocs had a good pearl. You don't always see a hypopion in endophthalmitis, so don't rule it out just because it's not there.
Wow. Okay. So that anatomical tour really maps out the possibilities. Now let's talk about the patient interview. What history questions are absolutely crucial?
History is everything here. Both strong medicine and MDocs gave great lists. You need the basics. How long?
Yeah.
Sudden or gradual? One eye or both? Then pain. How bad? Sharp, ache, burn, itch. Vision changes, any vision change, even if they say it's small. Photophobia, direct and consensual. Does it feel like something's in the eye or just gritty?
Discharge details.
Definitely. Color, consistency, watery, thick, stringy. Any trauma, even minor bumps, or they do for work or hobbies. Any risk, like grinding metal. Contact lens use absolutely critical. Ask every time.
Past history.
Yeah. Previous eye problems, surgeries. Any autoimmune conditions like arthritis or lupus, are they immunocompromised? And finally, associated symptoms, headache, nausea, vomiting, points towards glaucoma maybe. Fever could suggest endophthalmitis or orbital cellulitis. You got to ask the whole constellation.
Makes sense. Get the full story. Then the exam. What are the absolute must-dos for a red eye exam?
Okay, exam time. Start just by looking. What's the redness pattern diffuse? Ciliary flush. Any discharge. Check the pupil size, shape, reaction to light. Look for obvious foreign bodies, blood, or pus in the front.
And visual acuity.
Non-negotiable. First thing, check their vision. Snellen chart, ideally. Pinhole if it helps. Document it clearly, like MDoc stressed.
Okay, what else?
Check eye movements. Is there pain with movement that screams scleritis, like strong medicine and core EM mentioned? Then, fluorescein time.
After anesthetic, before pressure check if worried about rupture.
Exactly. Put in the dye, use the cobalt blue light. Look for abrasions, foreign bodies, those dendritic patterns of herpes keratitis. And always flip the upper lid if you suspect something's hiding under there. Look for sidal sign, too. That stream of fluid leaking out means the globe's ruptured.
Pressure check.
Intraocular pressure, yeah, if you're thinking glaucoma. Normal's roughly 10 to 20. And MBox had that good tip. Try not to press on the eyeball itself when you're holding the lids open, because that can falsely raise the pressure reading.
Right. And again, no dilating if angle closure is suspected.
Absolutely critical reminder. Slit lamp exam gives a much better view, but might not be needed initially just to decide on referral. Fundoscopy, usually less critical for the initial red eye workup, unless you suspect something specific posteriorly.
What about that phenylephrine test?
Oh yeah, strong medicine mentioned that. Putting in phenylephrine constricts superficial blood vessels. So if the redness blanches, it's likely conjunctivitis. If it stays red, the inflammation is deeper, episclera or sclera can be a helpful trick.
And the anesthetic drop itself can be diagnostic.
Right, MDocs pointed that out. If tetracaine makes the pain go away almost completely, it strongly suggests the problem is superficial, like a corneal abrasion. Doesn't help much for deeper pain like uveitis or scleritis.
Cultures?
Maybe, if you're really suspicious of gonococcal or chlamydial conjunctivitis based on the presentation and history.
Okay, that's a solid exam checklist.
Yeah.
So, distilling it down, what are those absolute red flag findings that mean call ophthalmology and now?
Strong medicines list is perfect here. Any drop in visual acuity you can't explain. A pupil that's not working right. Blood or pus in the front chamber, hyphema or hypopion. Any cloudiness of the cornea. A big corneal abrasion or one that's not healing. A foreign body you can't get out. That ciliary flush pattern of redness. And significant pain or major league photophobia. Any of those. Get help, urgently or emergently.
Crystal clear. Don't sit on those. Okay, let's try to put it all together now. Differential diagnosis and management. The MDoc's idea of splitting into painful versus painless red eye seems useful.
Yeah, it's a really practical way to start sorting things. So painful red eye, what's on that list?
Corneal abrasion or foreign body?
Right. Pain usually gets way better with anesthetic. Feels like something's in there. Fluorescein shows the defect. Treatment is lubricants, antibiotic drops, or quinolone if they wear contacts. Got to cover Pseudomonas. And MDoc says urgent referral for contact lens wearers. Emergent if you think it's an ulcer.
Keratitis.
Definitely painful. Often has that ciliary flush. If it's bacterial, often severe pain, maybe a hypalpion. Looks like an ulcer on fluorescein. Viral herpes simplex might show those branching dendritic patterns. Both need emergent ophthalmology. Fortified antibiotics for bacterial, antivirals for viral.
Anterior uveitis.
Moderate to severe ache. Consensual photophobia is key. Pain doesn't really improve with anesthetic. Ciliary flush, maybe small irregular pupil, need a slit lamp to see the cell and flare. Needs urgent ophthalmology for dilating drops and steroids.
Acute angle closure glaucoma.
The big emergency. Severe pain, blurry vision, halos, nausea, fixed mid-dilated pupil, hazy cornea, high pressure. Emergent ophthalmology to slam the pressure down with drops, beta blockers, alpha agonists, CAIs, maybe miotics later.
Synovitis.
That gradual severe boring pain, worse at night, hurts to move the eye, or maybe bluish sclera vessels don't move. Emergent ophthalmology, again, often needs systemic treatment like NSAIDs or steroids. Need to rule out systemic disease. Got to distinguish it from the milder episcleritis.
And endophthalmitis.
Severe pain, vision loss, often after surgery or trauma, maybe a hypopyon, maybe not. Absolute emergency. Needs immediate ophthalmology and antibiotics injected into the eye.
Okay, that covers the scary, painful ones. Now, what about the generally painless red eye causes?
Top of the list is probably conjunctivitis, diffuse redness, discharge. Viral is watery, maybe lymph nodes. Bacterial is